Okay, so what is hemostasis? Hemostasis refers to the term describing the responses to vascular injury. Okay? Does it make sense? Okay? So, injury happens. So, blood vessel is injured. The first step of hemostasis is vasoconstriction. Okay? Vasoconstriction results in the reduced blood flow to the affected area, and that results in the reduced blood loss. If you think about it, the whole goal of hemostasis is to minimize the blood loss in the case of injury. Does it make sense to everybody? Good? Okay. Now, second step. Platelet plug formation. So here's what happens in platelet plug formation. Check this out. So when the blood vessel is damaged, okay, endothelium, the layer of simple squamous epithelium that lines the inside of the blood vessel. Are you following me on this one? So that layer is inevitably damaged. And that results to the exposure of adhesion molecules and platelet activating molecules. So molecules such as P-selectin and von Willebrand factor and various types of integrins. So basically think of it this way. Suddenly, the molecules that are not supposed to be exposed to the blood suddenly become exposed because of endothelial damage. They may be found on the basolateral surfaces of endothelial cells. That makes sense? So point in case, so when this happens, this exposure happens, this results in the platelet activation. And there is one extremely cool thing here. Well, first of all, I can tell you, I worked with platelets. Those are some sensitive cells. If you have a platelet, so you can collect platelets, like you can take blood basically. Have you ever spun blood in the centrifuge? You know, take blood, you spin it down. At the bottom you have formed elements, on top you have plasma, and in formed elements you have at the very bottom you have a thick, massive amount of red blood cells, and between red blood cells and plasma you have what's called buffy coat. Buffy coat includes platelets and white blood cells. Okay, so you can collect platelets, you can isolate them eventually. There are methods for it. Isolation itself, no matter how gentle you are, will activate them a little bit. Does that make sense? And then if you have like platelet suspension, if you like shake it, that's it. It's activated. I had to mix my platelet suspension with a buffer. And I prepared the buffer and I filtered it through a very, very fine filter. Apparently it was not enough. So now imagine how idiotic it looked. I had to centrifuge a buffer for 50 minutes at 5,000 RPMs because there were tiny, tiny little speckles of dust in that buffer that just one speckle would initiate the whole activation reaction. They are incredibly sensitive. Does that make sense? It's like it's a pain in the ass to work with them. So platelet activation is an interesting process because it results in positive feedback loop. Okay? Because look at this, look what happens. Check this out. Imagine that you have an activated platelet here, okay? And you have a normal platelet here. When they interact, like with each other physically, that will result in two activated platelets. You see what I'm saying? They're like zombies. Like one touches another and now they're two zombies. On top of that, look. Platelet activation results in the release of thromboxane A. Okay? And what thromboxane A does? It activates platelets. So you see, it goes like the whole process is a cascade-like. Are you with me on this one? Now, if you think about the blood, like blood is a liquid, yeah, it's moving right, but check this out. You have trillions and trillions of platelets in the blood. One platelet gets activated, now two, look, 2, 4, 8, I don't know, whatever, million, 2 millions, 3 millions. So why doesn't your blood turn into a massive platelet plug every time you experience vascular damage? Like, technically it should happen, right? So there are a couple of reasons. First, intact endothelium releases intact, undamaged endothelium, releases molecules such as nitric oxide, which inhibits platelet activation. Does it make sense? So basically, if you have a damaged endothelium, around that area, oh yeah, you're going to have all of it. You're going to have exposure of platelet activating molecules. You're going to have the release of thromboxane A. You're going to have platelet activation. They're going to be sticking to the walls of the cell. They're going to be sticking to each other. So you're going to get platelet plug. Okay? Does it make sense? Like, they're going to be sticking to each other, going to form plug, right? Are you with me? Now, what about the adjacent healthy endothelium? Nothing of it is going to happen because it releases nitric oxide. Good? On top of that, blood is moving. It's not standing, it's moving. Does that make sense? And when it moves, it removes activated platelets, it removes thromboxane A, so it reduces the chances of the further platelet activation. Okay? Now, if you have a damage in the endothelium, yeah, the whole activation thing, the amount of thromboxane A will be so huge that movement of blood will not be sufficient, right? But imagine it's not like badly damaged. There's a bit of a damage, not too much. So here's my question. In which blood vessels the platelet activation, the formation of a platelet plug is more likely, in arteries or in veins? We talked about blood flow just recently. So blood flow will be removing stuff. In which vessels it will be removing stuff more efficiently? In arteries or in veins? In arteries, because it's faster. In veins, blood flow is much slower. So if you have a local activation, it is likely to stay in that activated state locally for a longer period of time. Does that make sense? I mean, you can get it in the artery, don't get me wrong. I have a video in the notes, and I think you can play it. Video of the formation of a platelet plug in an artery. And you can look at how long it took. So it's a mouse skeletal muscle, okay? It took an hour and a half to form a platelet plug, to form a thrombus in that little artery. In a vein, it will like 17-20 minutes. I mean, you can do it. So this kind of makes why I want to make this point. When people suffer from peripheral artery disease, are you familiar with the term PAD, peripheral artery, not PAD, PVD, peripheral vascular disease, okay? Also known as deep vein thrombosis. Look what happens. In deep vein thrombosis, they have, look at this, endothelial damage of some kind, inflammatory damage in it, activation of platelets, and since those are veins, those platelet plugs will be formed in the distant peripheral veins, mostly in the legs, where blood flows terribly slowly. Does that make sense? And then they will end up in places like your cerebral vasculature or coronary circuit, which will result in the stroke or infarction. Okay, we good? Now, what I want to highlight here, okay? Let's put blood flow. Removal of activated platelets from box 8A. Now, the last step that we need to address here is coagulation. So coagulation refers to the activation of the proteins, coagulation factors, in the plasma. Now, bear with me. I'm gonna tell you what you need to know, but I'm not gonna put this on the whiteboard because it's kind of memorizable. So, first of all, there are two coagulation pathways. There's an intrinsic pathway. There's common pathway. Not common, sorry. Extrinsic pathway. Okay. Now, look at me. Intrinsic means inside. Intrinsic pathway is activated when damage is pretty much restricted to the blood vessel. When damage is mostly restricted to damage to the endothelium. Does that make sense? So damage is relatively minimal. It all starts with a factor 12, goes to factor 11, then factor 9, factor 8, and then, 12, 11, 9, 8, and then factor 10. We'll get to factor 10 in a second. So, know the sequence of factors in the intrinsic pathway. Does that make sense? Do you understand what I'm asking? Like there's a scheme in the notes. Now let's talk about extrinsic pathway. Check this out. In extrinsic pathway, the damage is so big that basically tissue gets involved. Tissue that is beyond the blood vessel. Are you following me? So that results in the release of tissue factor, which activates factor 8, which activates factor 7. They form a complex. Here's the big point. Listen, the big, huge point here. Intrinsic pathway and extrinsic pathway, they converge on the factor, the so-called, forming so-called prothrombin activator. So prothrombin activator is the whole bunch of coagulation factors, factor 10, factor 5, calcium, phosphatidylserine. Look at the name, prothrombin activator. What do you think it does? What does it activate? Prothrombin, yeah. The whole role of this complex is to activate prothrombin. Does that make sense? So, prothrombin gets activated by prothrombin activator into thrombin. Okay, does that make sense? And thrombin activates protein called fibrinogen into fibrin. Okay? Does that make sense? Now, let me go over the coagulation one more time, making it a wholesome story. How about that? So look, here's what happens. Depending on the degree of damage, either intrinsic pathway is activated, or, as a matter of fact, both. Intrinsic and extrinsic. Okay? Now, intrinsic pathway has more steps, therefore slower, while extrinsic pathway has less steps, therefore faster. Which makes perfect sense. Look, if the damage to the vessel is confined within the vessel, check this out, you kind of have time. If the damage is so extensive that it spreads beyond and affects tissues now, you need to activate coagulation as fast as you can. Does that make sense? So intrinsic pathway gets involved. Both pathways converge on prothrombin activator. Prothrombin activator activates prothrombin, which, as the result of activation, forms thrombin. Thrombin is basically the enzyme itself. It activates soluble fibrinogen, which, upon activation, forms insoluble fibers of fibrin. And this fibrin, what's the word? And I want to use the English word just slipped to my mind. It's secure, strengthen the clot. The platelet plug. So this fibrin threads, they wrap around platelets, activated platelets, securing them in place. Does that make sense? Are we clear? Now, some clinical applications. First, this whole thing is called common pathway. Okay, so few fun clinical applications. First, let me give you some. Okay, first, have you heard about drugs like heparin? So heparin is basically a thrombin inhibitor. Prevents coagulation. Does that make sense? There are other drugs more specific than heparin, such as dabigatran and brand names. I think Prodexa is one of the drugs. They inhibit the conversion, as far as I remember, conversion from prothrombin to thrombin, or I don't remember which pathway they inhibit. Yeah, well, I think it's prothrombin. Okay. Now another clinical condition. Have you heard about hemophilia? When people usually describe hemophilia as blood doesn't clot. Well, it's not entirely true. Blood does clot, but in hemophilia, one of the components of the intrinsic factor is absent. I don't remember which one, neither should you, okay? The point is, blood coagulates much worse. So the person is at risk of severe bleeding. Does that make sense? That makes sense. Now, you may have heard about the drug called warfarin. Warfarin, it can be used, sometimes used as a component of rat poison, actually. But it's a pretty strong inhibitor. One of the factors that is essential for coagulation is vitamin K. Warfarin inhibits vitamin K. Okay? But my favorite, honestly, is aspirin. Everybody heard about aspirin, right? So what it was, so originally aspirin was used as the painkiller and antipyretic to reduce fever, all that kind of stuff, okay? But turns out aspirin is pretty good at the inhibition of the enzyme that produces thromboxane A. Check this out. When thromboxane A is reduced, platelet activation is reduced. Are you with me? Platelet activation by itself can initiate intrinsic pathway. So the less platelets are activated, the less chances a person has to develop a clot. Does that make sense? This is why aspirin is prescribed to people with increased risk for cardiovascular, thrombotic events like myocardial infarction or cerebrovascular accidents like stroke. What would be the downside of the use of aspirin? Yeah, bleedings. And actually there was recently a study of various anti-coagulation drugs in patients with COVID. They were looking at prophylactic dosage. So it's already established that prophylactic dosage of anticoagulation drugs improves the survival odds for patients because they are at low risk for stroke or myocardial infarction. Does that make sense? So they were comparing prophylactic with therapeutic doses, much higher doses. Turns out that much higher doses in patients with COVID result in more bleeding, which is not particularly surprising, but they don't improve the odds of survival. Does that make sense? Good. Now, last little bit. So you've got a platelet plug, okay? Is it supposed to be there forever? Obviously no. When damaged endothelium is restored, repaired, platelet plug has to be, so to say, resolved. And endothelium produces a molecule called plasmin, which destroys fibrin. That's one way to control it. Plasmin is derived from the molecule called plasminogen, and plasminogen is converted into plasmin by another enzyme creatively called tissue plasminogen activator, TPA. So essentially, to wrap it up, we've covered the coagulation, but once the repairs are done, tissue produces a lot of tissue plasminogen activator, which activates plasminogen, which is converted into plasmin, which destroys fibrin, which essentially leads to the dissolution of a clot. Okay? Does that make sense? Good. Now, last very small bit. Have you heard about the term disseminated intravascular coagulation? It's a very interesting phenomenon. Now, I want you to put pens down. Just imagine this. I'm not going to ask this on the exam. Just a really cool story. Imagine blood in a human, right? And suddenly, due to inflammatory processes, due to the platelet activation, patient forms multiple clots all over in the small vessels. Does that make sense? What it results in is this. When all those clots are formed, platelets are depleted. So suddenly there is very little platelets in the blood. Does that make sense? And since those are proper clots, coagulation factors are also depleted. Basically, all fibrinogen is converted to fibrin. And you have a paradoxical situation. A whole bunch of clots, but the rest of the blood now can't properly coagulate. It becomes very, leaky, and starts to leak through the blood vessels into the peripheral tissues. Disseminated intravascular coagulation it accompanies often conditions like sepsis, and what happens, tissue perfusion goes into trash because of the clots, right? There's no, they can't go through those small vessels. And on top of that, patient can develop hypovolemic shock because all that's left of the blood starts to leak from the blood vessels into the peripheral tissues. So lack of perfusion, hypovolemic shock, and people die. Does that make sense? Questions?